Hello everyone, welcome to the UQ 2020 Virtual Medical Student Research Conference and Showcase. So we are your MCs, Priya and Shamima. So this year we are having the pleasure of having a virtual research conference, and we hope that you will enjoy this lineup of amazingly enriching and interesting presentations this morning by our fellow medical students. So just a note that the e-posters are available for viewing on the Medical Student Research Portal, and all posters have already been judged, and the winners in each category will be announced at the end of the conference, together with winners of oral presentations. So this is our program schedule for today's event. So feel free to type your questions regarding oral presentations, which will be addressed at the specific Q&A sessions. And so without further ado, so I would like to invite our UQ Medical Dean, Professor Stuart Carney, to open this year's Virtual Medical Student Research Conference and Showcase.
Thank you very much, Shamina and Priya. For those of you who don't know me, I'm Stuart Carney, Medical Dean here at the University of Queensland. And I am delighted to be able to support the organizing team, Chloe, Cody, Shamina, Priya, Nicholas, Di Ely, and Brian Mallon in opening today's Medical Student Research Conference and Showcase. Before I proceed, I'd like to acknowledge the traditional owners of the lands upon which we meet. I'm speaking to you from Yagur and Turrbal people's lands. In particular, I'd like to pay respects to their ancestors and their descendants. And during these challenging times, as they relate to sort of COVID-19, but also sort of more broadly, as we reflect this week on mental health, I would also like to acknowledge that we have a lot to learn from First Nations peoples here in Australia and in the United States about connection to land and connection to each other. Social connectedness is critically important during the challenges we face here during COVID-19. And I do sort of encourage you to sort of take time out, ask each other, are you okay? And ensure that you get that balance in your lives so we can continue to flourish and thrive through these challenging times. What a time to be a researcher. Here in Australia, we are seeing unprecedented funding for clinical research. The MRFF has now sort of reached maturity, and Australia is in a very fortunate position to have both the NHMRC and the MRFF as major research funds at a governmental level to support clinical research. And there are lots of important issues, questions, hypotheses for us to test. I think one of the areas that does concern us as a community, however, is that at a time when government is investing more in clinical research, we're seeing a reduction in the number of individuals in the postgraduate arena who identify as clinician researchers. Therefore, it is particularly heartening that we have an event such as this today. Individuals here at the University of Queensland who have answered their call, and I understand that we received more abstracts this year, in fact twice as many abstracts this year as we have received for previous showcases. And as a consequence of that, thanks to the hard work of the organizing committee, there'll be 11 oral presentations and over 60 e-posters available for you to peruse, addressing some of the wicked and challenging issues that we grapple with as a community. And I think what COVID-19 has highlighted for us as a community of clinician researchers, individuals who bring to bear our expertise and our insights into clinical practice, is that there are lots of opportunities for us to really and truly make a difference. You as students at the University of Queensland are basking in the reflected glory of the work of our vaccine team, which builds on the shoulders of giants like Ian Fraser, who pioneered work with his team around HPV. We're grappling with questions around antimicrobial stewardship. We're seeking to improve the sort of quality of care to children, particularly following burns. We are seeking to address major questions around how can we ensure that the limited and finite resources we have to manage and care for our patients can be used most appropriately and cost effectively. Wicked and important questions for us here in Australia and also the United States and around the world. And it is an enormous privilege for us as a community to come together to celebrate the work that our students are doing here at the University of Queensland and to sort of nurture that emerging talent in the hope and expectations that you, our future clinician research leaders, will take that forward into your postgraduate training, will continue to be curious, will continue to ask the awkward questions, will continue to challenge the status quo, and assist us as a community to do better, to be better, and better serve the patients and the communities that we serve. So thank you for coming together today for the Medical Student Research Conference and Showcase, and thank you to our organizers for putting together such an impressive sort of morning here in Australia, evening for our colleagues joining us in the United States. And I'll now hand back to our MCs, Shamina and Priya. Thank you.
So thank you, Professor Kani. So before we start, just a reminder to our presenters that they have a total of 7 minutes for their presentations, and a bell will ring at the 6-minute mark to let you finish your presentations within the next 1 minute. And so with that, we will now begin our first oral presentation for the day. This is by Omid Fergie, a second-year medical student, on the suitability of viral white as a sterile material for intraoperative biomodeling. Omid, please.
Good morning. So do I just share my screen up here then?
Yes.
All right. All right, I think there we go. All right, hello everyone. My name is Omid Fergie, and today I'll be presenting on the suitability of VeriWhite as a sterile material for intraoperative biomodeling. This project was led by Dr. Michael Waggles, who is a plastic surgeon over at the Princess Alexandra Hospital. As well as in this project is Angus Hayes and Julian Vitale. So to start off with, I'd like to give some context onto this project. The Princess Alexandra Hospital owns an Objet 30 Pro 3D printer, which is compatible with VeriWhite material. And for added context, VeriWhite is a 3D printing material that is quite similar to dental resin. And since we have this 3D printer available at hand, we believe that this represents significant potential for improvement and growth in our operating theaters, as we can use this 3D printer for intraoperative biomodeling. And a little bit more detail on this. Using this 3D printer, we can use imaging done on patients such as CT imaging to create unique personalized surgical guides that can be used by plastic surgeons to better plan and prepare for their surgeries. And additionally, having these real 3D models, we can actually then further prepare for surgeries by molding certain surgical tools, as well as molding certain implants against these guides, so that when it actually comes to the operation, there'll be more work done beforehand, and so that the operation may run more smoothly. And this is all with the ultimate goal of improving patient outcomes. Once we have experience with these surgical guides, we believe that there's a potential for use for prosthetics, and that is where this project hopes to go towards eventually. Currently, there is no published records on how to sterilize VeriWhite. And so right now we are currently stuck at this phase where we have this 3D printer with a lot of potential, but we cannot necessarily bring in these models into the operating theater because we can't be sure that they're sterile. And we want to obviously reduce any chance of contamination and patient harm. So when we get to this actual project, our project has 3 aims. The first is to determine whether or not if VeriWhite can be sterilized for intraoperative use. And to do this, we want to achieve certification via 3 ISO protocols. ISO stands for the International Standardization Organization, and they're responsible for a good large subset of standardization for healthcare across the world. And these 3 ISO protocols I've listed specifically are relevant for autoclaving and then assessing the sterility of the autoclave process through the use of biological indicators, as well as additional microbiological assays. Once we have established that these materials can be sterilized, the next thing we want to do prior to using these surgical guides is to be sure that the sterilization process that we've chosen does not cause any structural deformities. And this is fairly important simply because we do not want to go through all this process of creating a unique and highly accurate surgical guide, only for it to be deformed by the actual sterilization process. And then lastly, once we have the first two aims kind of assured, we again want to eventually develop prosthetics. Once we finish these first two aims though, that's when we can start bringing in these models into the operating theater, and that's where we hope to be as fast as possible. So a little bit out of information about where we are currently. We've done a systematic review of the current available research, and we found no public protocols that exist to sterilize very white material. And after finding that out, we built a relationship with the Princess Alexandra's Center for Sterile Services Department. And we did this so that we can gain access to what exact sterilization procedures are available at hand. And this is important so that we can go from printing in-house to actually sterilizing in-house and using the models in-house. So once we heard from them, we decided to go ahead with the autoclave procedure as our first go-to, simply because it's such a standard protocol that is consistent across labs and hospitals across the world. And where we are currently is that we've actually outsourced this ISO protocol verification to a certified laboratory called Lexamed, and they will be able to run the assays necessary for those three ISO protocols listed on the prior slide. And in short, what that kind of looks like is that we will be giving them our prototypes. They will inoculate them with a list of pathogens, run the autoclave procedure, and then they will assess whether or not that is still sterile or not. And we've got an approved quote. And so where we are at currently is that we're designing and producing multiple prototypes to represent what we would call our worst case scenario models. And what I mean by worst case scenario is if we had to develop a surgical guide that is very complex with folds and small foramen and essentially very difficult to sterilize spots, if we can confirm that those models are sterilizable, then we will have certainty in the future that any future surgical guides will be sterile and can be brought to the operating theater safely. And so, as I said, we're looking for models that have small foramen and various clinically relevant structures. And we are aiming to have 7 prototypes. And we currently have 5 of the 7 designed. And so going on forward, what we want to do is, assuming that we find out that these models are sterilizable, we will then assess the structural integrity of the prototypes after sterilization. And to do this, we will use the same prototypes, but also use a couple additional structures to represent what would be the worst case scenario structurally. And so this includes structures with a thin lattice and multiple foramen. And what we'll do is we'll do a CT scan prior to the autoclave process and then another CT scan after the sterilization. And we will use these images to compare if there's been any structural deformities. And then in addition to that, we also want to make sure that this autoclave process does not affect the tensile strength of the prototypes. And so what we'll do is we'll apply various forces to the structures and see how much structural change there is. After we've done this, we will have some experience using these surgical guides, and we will then assess further properties necessary for prosthetic use. And this includes a significantly larger list of ISO protocols, and some of those are listed on the slide. But in briefly, these are things that could lead to cytotoxicity to the patient when implanted. And so once we have those done, we intend to identify certain organizations that can run these assays for us, and then we will be able to further implement another tool into our surgical toolkit. And in summary, the main goal of this project is that we have this amazing resource of this 3D printer here available. And the only thing that's currently barring us from using it to its fullest is some of these small sterility procedures. And if we can get those done, we can potentially improve patient outcomes. That is all I have for my talk. Thank you.
Thank you, Omid, for your presentation. So moving on to the second presentation of the morning is by John Hartberg, fourth year medical student, and he will be discussing about his project on the impact of oral ketamine augmentation on hospital admissions in treatment-resistant depression and PTSDs. John?
there? Are you there? Maybe. Someone give me a here.
Yeah, we can hear you.
Yeah, we can hear you.
Yeah. Okay, great. Okay. My name is John Hart. I work here at the UQ Ochsner clinical site. Tonight I am broadcasting from a hotel outside of Nashville, Tennessee. So welcome to Nashville, y'all. Before I begin, I would like to dedicate this talk to James Kiwi Johnston, known to his friends as Rock. Let me share this video. Oh, am I sharing the screen yet?
I'm not shared, John.
How's that? So I'd like to dedicate this talk to Rock. Rock was a true explorer in every sense of the word, and I had the fortune of meeting him for the first time at the Entheogenesis Australis conference outside of Melbourne in 2017, which is where I originally gave the expanded version of this talk I'm giving to you all. Let's talk about depression. So as Professor Carney so eloquently put, depression and mental health is a major issue in Australian society and our society in the U.S. Depression or major depressive disorders is the leading cause of hospitalizations for mental illness issues in Australia, and 44% of hospital admissions for depressive episodes are with patients that have previously been admitted. So there's not only a great need for depression treatment, but there's also an insufficiency of adequate treatments, and so people end up repeating the cycle over and over again. So that is where the interest in ketamine therapy has come into play. So ketamine has received a lot of attention in the last few years because it's a rapidly acting antidepressant. So whereas SSRIs and SNRIs may take anywhere from 2 to 6 to 8 weeks to start kicking in fully, ketamine peak effect in 48 to 72 hours. So it's an order of magnitude faster than other classes of antidepressants. And so there's been a surge in research. This graph represents the increase of papers published about ketamine's use as an antidepressant within the last 10 years. So you can see starting in 2010, there's this kind of exponential rise in research. And this graph only goes until 2017. So, in the last 3 years, presumably it's increased as well. So after ketamine administration, there are a number of ways to administer ketamine as an antidepressant, most notably the intravenous route, which is used commonly in infusion centers. And the recently improved intranasal spray developed by Johnson & Johnson. I should note that the intranasal spray is extraordinarily expensive because it's trademarked, and the delivery method, so it's much, much less economical than the IV route or the oral route that we were using in our clinic. So one of the issues with ketamine infusion therapy is that sometimes get a relapse or a recurrence of symptoms following treatment. And so the patient has to come in, every time after a series of weeks and receive another IV infusion. And intravenous infusions carry their own risks. I mean, patients don't like to be poked with needles, but there's also an increased risk of infection. So oral ketamine can be another route of administration that is, more patient-friendly and allows a more flexible scheduling in the clinical setting. So this is essentially the summary of the procedure that we use in an outpatient psychiatric practice in Brisbane. So you begin with patients starting with a dose, and then you titrate up until you get it's just a glass of wine feeling, so kind of a slight intoxication feeling. It's definitely far less than psychedelic type doses that you would find with IM ketamine or higher dose infusions. And then the patient comes in and receives a psychotherapy session And then following the session, they're given oral ketamine. They sit in a dark room for an hour. And then upon discharge, they're not allowed to operate cars or heavy machinery or tractors for, about 12 hours. The patient is allowed to take home to a 2-week supply to prove by the Australian government. And then during that time, the patient can continue with regular medication. So benzos can be used as breakthrough anxiety. Ketamine has very little drug-drug interaction, fortunately. So we published along with Dr. Garrett Wilcott, Dr. DeJones, published this in the Journal of Psychopharmacology in 2018. At the time, this was, with 37 patients, the largest study of oral ketamine published to date. So that was pretty exciting. And the results of this, because it was a prospective study, we weren't able to standardized measures. Instead, we looked at kind of these adjuncts or these proxies for functionality in the patients. So on the left here, what you see is a number of hospitalizations pre and post therapy. And so each one of those lines represents an individual. And on the left, you can see most individuals, with the exception of about 4 individuals, had significant reductions in psychiatric hospital admissions. On the right, you see the summation of those. And that overall, it was a 65% reduction in hospital admissions. We also took a look at number of days spent in a hospital. So there was a 70% reduction here in major depressive patients. This one also split up on the right side. You can see patients with and without PTSD concurrently with major depressive disorder, and they had reductions as well. So another concern with ketamine is the drug of abuse. So you might think, well, they need more and more over time. What we actually saw was an overall decrease in the amount of ketamine that people needed as part of therapy over time. So people either stayed the same or they reduced, and that's consistent with the proposed mechanisms of ketamine's antidepressant effects as sort of synaptic growth, and so you get an increased sensitivity in some of these circuits in the brain. So, in conclusion, what we know is significant reductions in depressive symptoms. They're trained weeks, so oral ketamine can be administered in safe measured doses in a controlled setting. Currently, ketamine is the most widely available psychedelic therapy modality available to the general public. Really, the only psychedelic therapy modality. There's other ones coming down the pipeline, most notably psilocybin and MDMA-assisted therapies, the latter of which I'm currently working on a study in New Orleans with. So that's exciting. Ketamine can also be used alongside other treatment methods like other medications and things like CBT. What still must be addressed is that this is still an experimental therapy. There's a lack of formal guidelines and protocols for practitioners to be able to utilize this in their own clinics. And then there's still physical harm and dependency concerns. And if you want to take a look at the paper, you'll see that that's not something that we found in this study, but it's still something that needs to be looked at. And then there's psychological considerations. Any modality that manipulates someone's state of consciousness, their well-being must be taken into consideration. So that is my talk. Thank you.
Thank you, John, for your presentation. So moving on to the next presentation. So this is by Belina Shabaro, second-year medical student, and her project was on the successful correction of sagittal imbalance by single-segment minimally invasive anterior column release with anterior to the psoas interbody fusion using hyperlordotic expandable cage and posterior instrumentation. It's a case series. So Belina, please.
Okay, I'm going to share my screen now. Can you see my screen? Yeah.
Yeah, we can see it.
I was going to read the title, but it is a mouthful, and since you read it, we'll skip that. Hopefully by the end of this talk, you will actually know everything that it states. Okay, so first off, let's review some terminology. Sagittal plane imbalance is structural spine deformity resulting in loss of lordosis or hyperkyphosis of the spine. So a normal, can you guys see my pointer here? Yeah, a normal sagittal vertical axis passes through the middle of C7 vertebral body. It is a vertical axis that should also pass through the posterior sacral end plate of S1. A misalignment, either anteriorly or posteriorly, can result in compensatory biomechanics, debilitating pain and disability, as shown on the bottom, due to postural instability. Traditionally, these deformities are approached posteriorly through the back, where the surgeon would resect the lower back muscles, the pedicles, as shown in this picture here, as well as the posterior vertebral body, and would perform a multi-level vertebral interbody fusion, which is this approach right here. So that's the fusion of the vertebra in order placing screws and rods on both sides in order to stabilize the spine. So this is essentially the multi-level stabilization of the spine that corrects the lumbar lordosis. Theoretically, the lumbar lordosis angle can be corrected either by decreasing the posterior, decreasing the angle of the posterior vertebral column, or increasing the angle anteriorly. And so an anterior approach to the lumbar spine can be performed through the belly over here, with an incision through the abdominal muscles, retraction of the abdominal organs, and resecting the anterior longitudinal ligament as shown here, as well as insertion of a hyperlordotic cage. So that's that device over here. So essentially, this is termed anterior column release, and it increases the anterior angle. Again, the result is the same. So it corrects the lumbar lordosis. ACR can be accomplished through a minimally invasive anterior to psoas corridor to the lumbar spine. And this approach is great because it avoids trauma essentially to the back muscles that are responsible for posture, and we're trying to correct posture. So the aim of this study was to evaluate if minimally invasive ACR can effectively restore sagittal plane imbalance and improve patients' pain and disability. We performed a retrospective chart review and included 3 consecutive patients who underwent this procedure in 2019 at Ochsner Health System. To evaluate the effectiveness of the procedure, we compared radiographic parameters pre and post, and also compared functional status such as pain and disability. The numeric pain score is a visual via a visual analog scale from 0 to 10, with 0 no pain and 10 maximal pain possible. And the Osvestry Disability Index is has a total score of 50. It evaluates disability because of low back pain and is calculated based on a percentage from the total score. So 80 to 100%, patients who score in the 80 to 100% of total score are bedbound. Patients who score between 40 and 80% of total score have severe disability that affects multiple aspects of their life. So our patients were aged 58, 64, and 66. 2 were females. The average BMI was 44. All patients had a single level spondylolisthesis, which resulted in single sagittal imbalance. The reason for this is because of their multiple comorbidities, such as obesity and advanced age. After ACR, we observed that all patients improved their radiographic parameters. We noticed the augmentation over here of lumbar lordosis of an average of 24 degrees pre and post, and a reduction of the sagittal vertical axis that I showed before. On average, that reduction was 120 millimeters, which is about 12 centimeters. That's significant. In addition, the Osvestry Disability Index, we can see that all patients improved significantly by week 6, and this improvement was sustained through 9 months, as well as pain was improved by week 6 significantly for all patients, and that improvement was sustained through 9 months. I just want to direct your attention now to case 2. There's nothing special about this case. It just showcases what I was trying to show before. So the sagittal vertical axis of this patient is right here. This is C7. It should pass over here through the posterior end plate of S1, but it doesn't. It is 146 millimeters anterior to it. After the minimally invasive anterior approach, as you can see, this is only a single level fusion. We can see this, how the patient is actually straight up now. So this sagittal vertical axis almost passes. It's only 4 centimeters. So there was a significant 100 millimeters reduction in SVA, as well as an improvement in lumbar lordosis. And also, obviously, this patient also improved their pain level and disability level, and that was sustained at 9 months follow-up. So in conclusion, single spondylolisthesis can result in severe sagittal plane imbalance among patients with other risk factors such as obesity, advanced age, etc., osteoporosis. Restoration of sagittal balance and improvement in pain and disability suggests that this approach, this minimally invasive approach with the use of hyperlordotic cage through the anterior to psoas corridor is a promising approach alternative and has the potential to provide similar results to the traditional posterior multilateral occlusion. And with that, I would like to thank you for your attention and to thank my mentors at Ochsner, specifically Dr. Dennis, as well as UQ Summer Research Scholarship that provided a connection for me and an opportunity to work on this project.
Thank you, Valina, for your interesting project. And so the next presentation is by Patrick Biggins, fourth-year medical student, on his project on the COVID-19 pandemic and unexpected opportunity to optimize Australian tertiary ED workflow. Patrick, please.
Good morning, all. I'll just share the screen now. Great, so that should be showing up. So thank you to the organisers for giving me the opportunity to present this research. A bit of background first on COVID. So we know that the pandemic caused a drop in patient presentations globally, and particularly in some of the regions first affected in Europe and the US, we saw decreased non-COVID-19 related emergency department presentations and pertaining to decreased ACS, decreased stroke, and decreased respiratory, cardiovascular, and GIT presentations. What we didn't know at the time of this research is whether we saw this in Australia. And so we wanted to investigate this, and anecdotally, we believed that presentations were decreasing, but we didn't know the specific numbers. And it was important to answer this question for planning purposes for the current pandemic, as well as for future pandemics. So our research question is, as stated, so were changes seen in patient presentations or admissions during the first wave? And to address this, we did a retrospective cohort study at the PA Emergency Department, so the Tertiary Referral Centre for South East Queensland, one of them. And we looked at all patients presenting to the emergency department during the first wave of COVID in Australia, so March and April 2020, and compared that to the preceding 2 years as the control group. To address this, we first looked at overall presentations, and we saw that there were changes. Surprisingly, they actually increased in March by nearly 11%, which equates to roughly an extra 20 patients per day turning up to the ED. When we looked at April, however, they actually decreased by nearly 20%, which equates to roughly 34 less patients turning up to the ED per day. And looking at the data, there seems to be this inflection point that you can see with the red circle at around about late March, where it drops off steeply. So we were worried there was a little bit of a confounding factor in the data. And when we did break it down further, we found that the fever clinic, which saw low acuity, so triage category 5 patients requesting COVID swabs, that ran from the 4th of March to the 23rd of March inside the ED, and that represented this massive spike in numbers. Once that was moved out of the ED and into the community, you see that steep drop off and reflects probably the more true patient presentations during the COVID pandemic. Going into the data further, we looked at all of the Australasian triage category scales. So 1 to 5, 1 being your imminently life-threatening conditions and 5 being your typical sort of GP conditions that you have more time to treat. And we saw that the mid to high categories, so 2 to 4, significantly decreased across the 2 months of the first wave, which suggests either that there are less of these presentations in the community, or these patients simply aren't turning up to the ED, which is the more concerning assumption, as it means that we might be missing some serious pathologies. To look at it again, we then delved into the presenting complaints and looked at the top 6 presenting complaints, which represent the majority of patients presenting to the ED. And again, we found that 5 of the top 6 presenting complaints significantly decreased in the COVID months. suggesting, again, that patients may be avoiding the ED, which we do know from studies in the United States that is occurring for fear of contracting COVID. Looking at the data further, we can make assumptions that the limb and joint pain, which are acute presentations, could be decreased from other factors like cancellation of community sports and things like that. But the decrease in chest pain, we did some preliminary investigations and looked at myocardial infarction diagnoses, and we did actually find that they unexpectedly decreased during COVID. So given that MIs are typically the result of more chronic health factors, it's unlikely that the COVID pandemic actually caused decreased MIs. So it suggests that patients might be avoiding coming in, which is a problem long-term, as these patients might present in a more serious manner. Looking at the top 6 admitting specialties, again representing the majority of ED patient presentations, we saw 5 of the top 6 significantly decreasing again. And this time it's likely more a multifactorial and specialty dependent reason why they decreased. For example, general surgery, you could attribute that decrease to cancellation of elective procedures, increased telehealth, and changes to admission criteria. And again, we wanted to look at the acuity of these patients. So preliminary discussions with the gastro team found that although their overall patient presentations decreased, the number of emergency scope procedures they performed didn't change that much, which suggests that unlike the cardiology and the MI data, you're not seeing a loss of those high acuity patient presentations across all specialties, which again suggests that with our future planning for the pandemic, we need to look at individual specialties rather than having an across the board policy for the hospital. So in conclusion, we do acknowledge some limitations with the data, specifically that we had that initial confounding factor with the fever clinic being inside the hospital for the first month of the pandemic response in Australia. And also that we are only looking at the first 2 months of what is clearly now looking like a protracted pandemic. And so we haven't seen all of the data from May onwards, but there are some conclusions we can take from this study. Firstly, that we did see less patients presenting in that mid to high acuity range from the COVID months compared to the preceding control years. And next, that the clinical redesign was a contributing factor to changes in the ED patient presentation. So in Australia, we had the whereby you effectively had 2 emergency departments inside one. And that was possible because less patients were showing up. And it's important that we have a safe minimum number of patients going forward so that we can maintain that smooth workflow. Next, the preliminary discussion suggested that changes to treatment pathways explain at least some of the reduction in ED attendances, as discussed before. But we are worried that patients may start presenting with an increased rate of complications from otherwise manageable diseases. And that's something that we'll need to consider going forward with community care and patient education. So in conclusion, we hope that these findings provide a launching pad for discussions about how to maximise our response to COVID and the ongoing response. And it's the starting point of a study also looking at ED length of stay and hospital length of stay to see if any changes have happened in those spheres in the COVID pandemic. But I'd just like to thank the research team that I worked with, so all of the doctors in the PA emergency department, and yeah, hopefully that stimulates a discussion. Thank you.
Thank you, Patrick, for your presentation. So we've come to the end of the first set of presentations, and the presenters are happy to take any questions that anyone has. Please do put in your questions in the Q&A. So there's a question for Patrick Biggins. So thank you for your presentation. So there are two questions for you. Firstly, I note you mentioned a decrease in patient presentations of around 30 patients per day. Do you have any idea how this translates to staffing requirements in the ED? I.e., does this equate to a reduction in the number of nurses or doctors required on a given day? Second question for you is, were you able to see whether calls to QS were impacted during this time frame? And I wonder if patients were still seeking emergency care but declining retrieval to hospital. So Patrick?
So thank you for the question. First one, we didn't look at whether or not there were changes in staffing requirements because of this decrease. It's a bit difficult at the moment, I would hypothesize, given that the departmental workflow has been segregated basically into your non-COVID and COVID streams, so you effectively have duplicated teams. Logically, you would think that you could afford to have decreased staff on if there are less patients coming through, and that would obviously have implications on departmental budget and sort of redeployment of those resources elsewhere if they are now suddenly available. So that would be worth looking into. To answer the second question, that is another limitation of this study in that we didn't have the community data. So unfortunately, there's no way for us to quickly retrieve all of the GP patient presentation data, or we weren't able in the time during my elective to get the QAS data for this period. And so we're not sure if patients were avoiding the ED for fear of contracting COVID, as we know happened in the United States and other countries, and were instead showing up to their GP clinics with these sorts of heart symptoms. You would think, though, that if the patients presented to the GP clinic with chest pain, the standard practice for those clinics is to refer them straight to the ED anyway by ambulance. So you would think that we'd still capture those patients in particular, but it is a gap in our data, and it's worthwhile exploring further.
That's the only one that it can't let you go on.
So there's another question for Bolino. So the question is, are there any complications attributable to the anterior approach?
Sorry, I had to unmute myself. As far as we know, the anterior approach has lower level of complications, so lower minimal blood loss, as well as less trauma to the back muscles, and so recovery is faster, hospital stay is shorter. However, it is only recommended for the lower lumbar spine because there is obviously the aorta lies over the lumbar spine. So the approach is only appropriate for L4, L5, L5S1 deformities. Does that make sense? So yeah, a major complication would be trauma to the aorta and bleeding, and therefore a vascular surgeon is usually on call when those operations are performed. But yes, thanks.
Thanks, Melina. So we'll move on to the next set of presentations now. Our next speaker is Cody Freer, a third-year medical student who will be presenting on the cost effectiveness of negative pressure wound therapy as an adjunctive treatment for pediatric burns, evidence from the Sonata and C randomized controlled trial.
All right, thank you very much. So today I'll be talking about a critical element of decision-making surrounding which interventions are employed in clinical care, cost effectiveness. And before I begin, I'd just like to note that some funding for this study was provided by Smith & Nephew in the form of a research grant. Now, last year, the US FDA approved a gene therapy called Zolgensma that carried an eye-popping price tag of $2.1 million per patient. It's the most expensive drug currently on the market. Hearing that price might make you wonder, is it worth it? How can we even tell? And that is where cost effectiveness comes in. Broadly speaking, a cost effectiveness analysis can yield 4 possible results, represented here on this cost effectiveness plane. I like to think of it like buying a new car. So imagine you're like me and you have a Prius, you know, it's the ultimate chick magnet, I know, but you're in the market for something with a better cost to speed ratio. Now in this first quadrant, you have an Aston Martin, more expensive, but carries a lot more oomph. In the second quadrant, you have the worst combo, costly and slow. Not good, you know, unless you want to take over Gotham. The third quadrant is a jalopy, slow but cheap. And finally, the sweet zone, quadrant 4. Think Mad Max Fury Road, cheaper and faster. Interventions that fall within this quadrant are considered dominant. So say you're in charge of a public health system. It's your job to allocate resources and balance the budget. One day you hear about this promising adjunctive therapy in burn care, negative pressure wound therapy. Now, if you're not familiar with negative pressure, at its most basic level, it involves the application of a subatmospheric pressure or vacuum to a sealed wound environment. There's evidence that it can aid wound healing in certain situations by removing edema fluid, extracting potentially harmful inflammatory factors, and stimulating neovascularization and cellular proliferation. Now, if negative pressure can accelerate the healing process and reduce the risk of scarring, it could have major implications for patient outcomes as well as healthcare costs. And keep in mind that burn care is one of the most expensive domains in all of healthcare. Now, a small number of randomized control trials have suggested negative pressure might improve burn wound healing, but not a single one collected any data pertaining to cost. Now, as the head of a healthcare system, this would be quite frustrating. You have a promising therapy that could improve long-term outcomes, but purchase of a single vacuum pump will cost you $16,000. Is it worth it? If only there was an RCT that undertook a cost-effectiveness analysis to guide your decision-making. Well, we've got you covered. As part of my PhD, I performed a trial-based economic evaluation of adjunctive negative pressure in the acute management of pediatric burns. At the Queensland Children's Hospital, we recruited children with burns covering less than 5% of their total body surface area who presented within 1 week of injury. Participants were randomized to either standard care consisting of silver impregnated dressings or an intervention combining standard care with adjunctive negative pressure. Healthcare costs were calculated by recording the materials, equipment, and personnel directly involved in the care of each participant's wound up to 6 months post-healing. So if you ever walked in the burn center during the trial, you would have probably seen me furiously recording every square centimeter of adhesive, bandaging, and gauze that came anywhere near the study's participants. As you can imagine, I was very popular with the nurses. Now, labor was costed according to state-based industrial award rates, and market prices for wound care products were obtained from the hospital's consumables pricing list. A total of 101 children were randomized, 54 to the control and 47 to the negative pressure group. Now, due to its direct relationship with the risk of scarring, time to reepithelialization was selected as the primary outcome variable. And here are the Kaplan-Meier curves for the negative pressure and control groups. Negative pressure, we found, produced a statistically and clinically significant reduction in expected time to reepithelialization by 22%. The negative pressure group also showed reductions in dressing change requirements and referrals to scar management. The number of theater operations was not large enough for an inferential analysis, but it's noteworthy that the control group included 4 of the 5 patients who required grafting and 3 of the 4 who needed a dressing change under general anesthetic. Now, if you want to read more about our clinical results, they were recently published in the British Journal of Surgery. Now, based on these findings, negative pressure appeared to improve clinical outcomes, but that's only one piece of the puzzle. What about cost? When we added up the costs of dressings, labor, medication, scar management, and theater operations, mean overall costs per participant for the control group totaled about $1,700, compared to $900 for the negative pressure group. The greatest reductions were seen in the areas of scar management and theater operations. Now, remember our cost effectiveness plane with the 4 quadrants. Lower costs at the bottom, Greater effectiveness defined here as faster healing to the right, Mad Max dominance in the bottom right. Now, this is what the primary analysis with bootstrap resampling revealed. 98% probability of faster reepithelialization in the negative pressure group, 90% probability of lower total healthcare costs, and an 89% probability that negative pressure dominated standard care. Everyone's watched Mad Max. Our findings remained robust to a pair of sensitivity analyses. In the first, we used an alternative time to reepithelialization estimate for grafted patients. This yielded a dominance probability of 83%, so still very high. The second sensitivity analysis employed a more conservative estimate of theater costs, yielding an 82% probability that negative pressure was dominant. These results suggest that adjunctive negative pressure is not only a cost-effective strategy, but a dominant one, decreasing time to reepithelialization and total healthcare costs. Of course, there were a few limitations that are worth bearing in mind. First, the trial had a time horizon of 6 months post-healing, so any scar interventions undertaken beyond that time frame would not have been captured. Second, the cost estimates were greatly affected by expensive theater operations conducted in a relatively small number of patients. Most of these operations involve children in the control group, which could have been a result of negative pressure exerting a beneficial effect on injury severity. However, further investigations with larger sample sizes are warranted to better understand the intervention's impact on the need for surgery. Finally, this was a single center trial using costings provided by the participating hospital. So our findings may not be applicable to other services and jurisdictions. We are currently in the process of planning a multi-site follow-up trial. So in conclusion, negative pressure was a dominant adjunct to standard dressings in the acute management of small area pediatric burns, decreasing time to reepithelialization and total healthcare costs. The greatest reductions were observed in the areas of scar management and theater operations. I'd like to acknowledge all my supervisors and the Center for Children's Burns and Trauma Research for their support. Thank you for this opportunity to share my research, and I hope you all have a lovely day. Thank you very much.
Thank you, Cody. That was a great presentation. Our next speaker is Dylan Kendrick, a second-year medical student who is presenting his work on the comparison of sleep problems in children with Down syndrome and autistic spectrum disorder. Dylan?
Yeah, thank you. So as they said, I'm looking at comparing sleep problems in children with Down syndrome and autistic spectrum disorder. And this is in order to just assess some of the feasibilities of adapting some sleep interventions for kids with autism and making those a little bit more suitable for kids with Down syndrome. So a little bit of background. Autism spectrum disorder is that early onset neurodevelopmental disorder with an estimated prevalence of about 18.5 per 1,000 births. Typically, these individuals have difficulties with communicating and social interactions, as well as the presence of some stereotypical and repetitive behaviors, as well as an intolerance to the change in surroundings and their routines as well. So with Down syndrome, this is a set of mental and physical and functional abnormalities, and this is due to that additional 21st chromosome. Some of those physical abnormalities that you might see as well in this group is going to be that slanting of the palpable fissures, the flatness of the bridge of the nose as well, and then some midfacial hypoplasia. In terms of sleep, prevalence of sleep disorders is greater in children with these neurodevelopmental disorders, including Down syndrome, as well as those chronic pediatric or psychiatric disorders such as ASD. Commonly noted issues in sleep is going to be troubles initiating or maintaining sleep, these kids waking up in the night as well, being sleepy during the day, and then some of the respiratory issues with sleep disordered breathing. Managing these things with the respiratory side of things, you're going to treat it how you normally would with adrenal tonsillectomy as that first line therapy. It's going to be that treatment of the non-respiratory sleep issues or the behavioral sleep problems. It's going to be a little bit more challenging, particularly in these children with this underlying disability. So then that brings us to the aims of the study, and kind of this preliminary data that I'm presenting today is just going to be on that first dot point there, and just comparing the sleep habits and sleep disorders between children with Down syndrome and children with ASD. A little bit further analysis is going to be looking at the behaviorals between the two groups, as well as exploring the relationship between sleep habits and these behavioral patterns. And the reason for doing this is because there's such scarce literature regarding sleep interventions available for kids with Down syndrome. And so by comparing them to the group with ASD, we can hopefully adapt these sleep interventions for autism and make them a little bit more suitable for kids with Down syndrome. So working very closely with Deakin University, they've collected the data on the kids with ASD. And then here at the Queensland Children's Hospital, we have the data for the Down syndrome groups. With our demographics, we have a wide pediatric age ranging from 3 to 16. The sex of the groups, with the ASD group being predominantly male, and then our Down syndrome group has a nice kind of 50-50 split of male and female. And then in terms of height, weight, and BMI, they are very similar across the two groups. For our measures then, and the data that I'm going to present today is just looking at this sleep habits questionnaire. And what this questionnaire does is it looks at both the medically, so that's going to be that respiratory side of things, as well as the behavioral-based problems that you see in sleep with these children. There's a number of different subscales that are taken out of this questionnaire. It includes bedtime resistance, sleep onset delay, sleep duration, the anxiety with sleep, waking up in the night, some of those parasomnias, sleep disordered breathing, and then daytime sleepiness as well. So a significant cutoff score of 41, anything higher that is going to indicate that there's that sleep disorder present within that kid. On the behavioral side of things, we use the child behavioral checklist, looking at identifying emotional and behavioral problems in these children. Deakin University used a slightly different checklist, but we've been able to match the questions between the two measures and assess similar behavioral issues seen in these kids. So if we look at some of these results that we've pulled so far, the white here is where the two groups have been similar in terms of the sleep habits questionnaire. And then highlighted in green is where we see some of those differences. So with this, we see that falling asleep within 20 minutes of going to bed, that's going to be more likely seen in a kid with Down syndrome from our populations. Sleeping the same amount of the day, restlessness at night as well, moving into someone else's bed and grinding the teeth, that's also going to be more likely seen in this population of Down syndrome children. Maybe waking up a little bit more distressed, sweating, screaming, and inconsolable. That's going to be favored and more likely seen in kids with ASD. Waking up in the night as well, and then waking up by themselves, we're going to be seeing that a little bit more in Down syndrome children as well. Here's just some raw data that we have, just kind of a representation of some of that significance that we've seen and kind of just that distribution that we see in the questionnaire. So with restlessness and moving a lot during the sleep, in that autism group, we see it's going to be recorded kind of in that sometimes area. Whereas when we look at the Down syndrome group, almost 80% of the respondents are going to say usually our child with Down syndrome is restless and moving a lot during sleep. If we look over at the waking up during the night, those children with autism, it's going to be predominantly rarely seen as reported there, whereas we see a little bit more of an even just distribution in our kids with Down syndrome, just increasing that likelihood that we're going to see these children waking up in the night. So if we summarize some of those key findings, we see that our kids with Down syndrome, they seem to have that better sleep onset and a little bit more consistency overall in their routines and the amount of time or the amount of sleep that they get each day. We also see that greater restlessness with sleep and that greater tendency to wake during the night, whereas I kind of mentioned as well that ASD group is more likely to wake a little bit more distressed. So with these findings then is what we're going to be looking at is just using those similarities just to make sure that we can use the interventions that are already out there for ASD. But it's going to be that these differences, these subtle differences that we see that are going to be driving these adaptations to these interventions and hopefully allowing us to target these kids with Down syndromes to hopefully they can get better sleep outcomes. So this might be more focused on the sleep throughout the night, as we saw with the night awakening was a little bit more prevalent in the Down syndrome group. With our next step then, working with Deakin University and evaluating some of that behavioral data. And then this is going to help us hopefully pinpoint some of the methods that we use in these adaptations for the interventions. So this might be the use of more pictures or images in order to communicate with these children and a little bit less verbal cues. And that's all I've got for you. Thank you.
Thank you, Dylan. That was a really great talk. Our next speaker is Chloe Yan, a fourth-year medical student who will be presenting her work on restricted diet drives autism gut microbiota associations, which are weak compared to age, dietary, and stool traits. Chloe?
Awesome, thanks so much. Does that look okay? Okay, awesome. So hi everyone, I'm Chloe, and today I'll be presenting our results that restricted diet drives autism gut microbiota associations. So autism is a neurodevelopmental condition that is diagnosed based on social difficulties and repetitive and restrictive traits. There's been increasing interest in autism in the gut microbiome, which sounds a bit funny perhaps, but the reasons for this are firstly because gut conditions are common. Secondly, the microbiome is sort of a hot topic for many traits, whether it's neuropsychiatric, cardiometabolic, or immunological. And in fact, for autism, there has even been recent progression to phase 1 fecal microbiota transplants, otherwise known as transfusions. Furthermore, some animal studies out there have been suggesting a causal link between the microbiome and behavior and neurodevelopment. But the field has so far been hampered by studies that are underpowered with small sample size, that inadequately correct for multiple testing and confounders, and the use of 16S technology, which is outdated compared to metagenomics technology, which provides deeper functional and taxonomic insights. And in fact, the field stands as having more reviews than primary articles, which is a pretty damning statistic. So here we present the largest autism metagenomic study to date. And for that, we leveraged the Australian Autism Biobank and Queensland Twin Adolescent Brain cohorts. One of the really exciting aspects of this data set is the really deep phenotyping. So that includes psychometric measures, dietary questionnaires, and stool consistency scores. And then to get some really deep functional insights, we use Microba's large microbial database and profiler. Here's a snapshot of the study design, which includes a comparison of 50 sibling pairs, which is nested within this case control comparison of just under 100 per group. In terms of group demographics, the kids range in age from 2 to 17, and there was a bias towards males. And this is expected because autism is more likely to be diagnosed amongst boys than girls. The first question we asked is how much of the variance in autism diagnosis can be explained by the microbiome? And this is an important question because it gives us a theoretical upper limit of how well we can predict autism or any other trait based on microbiome data. And we fed into this analysis a couple of different data sets. We included some microbiome data sets at the species level, as well as the gene level, so about 1,000 species and a couple of million genes within these data sets. And then we also fed in this diet survey of 120 food level items, just because we were interested that perhaps that could also contribute. We first looked at age as a benchmarking trait, and that's because a previous study has estimated that this proportion of variance explained is around 30%. And just to interpret these graphs, the scale for variance explained is from 0 to 1, or 0 to 100%. And our species level estimate was consistent with this, but our gene level estimate explained almost all of the variance in age. So in stark contrast, there was basically no relationship between autism diagnosis and the microbiome, but there was a significant relationship with this diet data, which was our first clue that perhaps this is something worth looking into further. We also looked at stool consistency and dietary profiles, reasoning that these are more directly and intuitively associated with your poo, your gut microbiome. And we did find strong estimates here as expected. We then wanted to dig a bit further. We first looked for individual species that could be markers for autism diagnostic status. And we found limited evidence for this. And we, in fact, could barely replicate any of the previous associations that were out there. The single exception to this was this bacteria called Rhambutia timonensis. There was no association with species diversity, nor with stool consistency. But again, there was a clue from diet, with the group of children on the spectrum consuming less meat. So overall, this led us to conclude that there is limited direct evidence for association between autism and the gut microbiome. But we then took a step back, going back to one of the fundamental pillars of autism diagnosis, which is repetitive and restricted behaviours and interests. And we reasoned that perhaps this may be manifest in having a more restricted diet. That is, are kids on the spectrum more likely to be fussy eaters? And they were, as you can see in this plot here, where this is the group of children on the spectrum, siblings and unrelated kids. And then we also found a strong correlation between dietary diversity and species diversity. But there was no association between species diversity and autism diagnosis, as we can see here, which then suggests that it's a downstream mechanism. We also found significant association between species diversity and stool consistency. And furthermore, all of these associations stood up to inclusion of covariates, as we can see here, and they were quite extensive. And this light green shows species diversity, yellow shows dietary diversity, and the Y variable, the dependent variable, is shown as the headings. As we can see, we're still past this dotted line. We then probed further, asking whether autistic traits or specific measures of them were also associated with restricted diet. We looked at measures of the autism spectrum on the genetic and the phenotypic levels, and we found significant associations, as was the case for restricted and repetitive traits, and also marginal evidence for association with sensory preferences. And this is interesting because children on the spectrum tend to have differences in how they process sensation. And it makes sense that, for example, if you are more sensitive to taste or smell, then you maybe have a more restricted diet, you may be a more fussy eater. We caveat that this is a relatively small data set in genomic terms, and these associations aren't overwhelmingly strong, but overall, I think that they add to this picture of this mechanism that we have proposed here. So in conclusion, we found that direct microbiome autism relationships are weak, and particularly when compared to other traits. But autistic traits and preferences seem to restrict diet, and that this in turn drives autism gut microbiota associations. There are a couple of important implications to this work. Firstly, I think it helps to temper this hype around autism and the gut microbiome. Secondly, it underlines the importance of adequate nutrition for children on the spectrum, because we know that a more diverse microbiome is associated with better overall well-being and health. And thirdly, I think it's important to consider the impact of behavior and diet as being upstream factors in microbiome causality, rather than assuming the sexier hypothesis of the microbiome controlling you. So in conclusion, I'd like to thank the huge team who have contributed to this pretty big project, and in particular, the families who generously have contributed to these studies. Thank you.
Thanks, Chloe. We will now be taking some questions. So we have a question from before for John regarding ketamine therapy in the first block. You mentioned there are a few drug-drug interactions with ketamine. Is there any issues with combining this therapy with ECT, and do you have an idea about how this therapy will fit into current algorithms, i.e. is it proposed as first line or reserved as last line?
Hey there, sorry, can you hear me? My video cut out for a second, but I think it was, the question was directed towards adjunctive therapies that ketamine could be used alongside, including ECT and, is that correct? And then I'll just speak to the last part of the question. So this particular therapy, if you read the research paper, was specifically for treatment-resistant depression, which in our study's case, we defined as failure of 2 pharmacologic treatments for depression. So some studies characterize treatment resistance as failure of 1, but we characterized it as 2. So that was part of the inclusions criteria. And then as far as use alongside other therapies like ECT, so there's this kind of like funny historical footnote in that it's been the case in the past that ketamine has been used as an anesthetic during ECT procedures, and there's some thought that perhaps that may be that some of the success of ECT can be attributed to ketamine. Now, that's not across the board, obviously, because propofol and some other things are used as anesthetics as well. Is there any more parts of that question I didn't address?
No, I think that's good.
Okay.
Thank you. So the next question is for Dylan. Thank you for this interesting research. With regards to the children with ASD and their propensity to wake distressed, is there a way to determine whether these children have an underlying anxiety or other conditions which may also be disruptive to sleep?
So from what I can tell, with children with ASD, there's a number of different medical comorbidities that can contribute to these sleep disturbances. So that can be some biological things like epilepsy or gastrointestinal issues. But there's also those psychiatric conditions as well, depression, anxiety, and ADHD. I think it would be those behavioral questionnaires and analyzing those answers and scores that would help us maybe nail down why these children are waking up a little bit more distressed than our Down syndrome group. So that would be a little bit later that we look at the behavioral issues that we see in these populations.
Great, thank you. Our next question is for Cody. Fabulous talk. Could you elaborate more on how you did the bootstrapping in this analysis?
Yeah, that's a great question. Would I be able to share my screen?
Yeah, sure.
Thanks. All right. So again, fantastic question. So for those who aren't aware with bootstrapping, it's a statistical method that allows you to independently sample from your original data set to create many different simulated data sets. And this helps you account for uncertainty within your sample. And this is a nice visual representation of kind of what bootstrap resampling achieves. And just to go back to earlier, my cost effectiveness. Yeah, so these graphs display the bootstrapping results, and each point within the graph represents mean difference in cost as well as days to reepithelialization between the two groups in each simulated data set. So there are 2,000 of these points because we replicated our sample 2,000 times. Great, and that's it.
Thanks, Cody. There's actually another question for you. With costs of TNPT being related to pump, is a proprietary pump required, and what are the characteristics required in a pump, like variable pressure, oscillation, infusions, etc.? And also related to the pump, the longevity of the pump.
Yeah, that's a great question, and it's another kind of limitation of this study is that we used a single pump set to a continuous subatmospheric pressure. And in negative pressure wound therapy, there is there's a wide variety of vacuum pumps that you can use that are available on the market, and you can set them to different settings. So intermittent rather than continuous pressure, and also different subatmospheric pressure levels. We selected the particular setting that we used in this trial because previous research suggested that it produced the best results, especially with children. Higher settings or higher subatmospheric pressures, which are usually used in adults, so pressures of about 125 millimeters of mercury, can result in pain in children. So we dropped that a little bit. And higher pressures can also lead to hypergranulation, which can exacerbate scarring. Now, what we're doing in our follow-up trial that we are planning right now is to also compare different pumps. The pump that we used is called Renesys Touch, and it's a portable device. So in theory, patients are allowed to return home and carry on their regular daily activities while receiving negative pressure. But the pump is quite sizable, especially for young children. We like to say that it's about the size of a Harry Potter book, one of the later ones. So if you are a very young child, then obviously it's very difficult to mobilize with these devices. So what's great is that they've devised new pumps that are much smaller. They're called ultra portable pumps, and you can actually fit these in your pocket, and it can deliver the same amount of negative pressure that's administered by these larger portable pumps. And evidence, very limited evidence, but there is evidence, suggests that these ultra portable devices are actually cheaper than the larger portable devices because, first of all, the price is just substantially lower, like on the factor of, many thousands of dollars. And also they require less of the additional kind of resources that are needed in negative pressure. And that's stuff like gauze and adhesive and tubing. So by reducing all of those resources, these ultra portable devices could prove actually more cost effective than the device that we found to be cost effective and dominant in this study, while also being more manageable for younger patients. And I suspect that hopefully when we get that multi-site trial off the ground, we will find that total healthcare costs are substantially reduced in those children who receive those ultra portable devices. Thanks.
Thanks, Cody. So we have a few more questions, but we're gonna get back to the talks and hopefully answer them at the end. That's all right. Our next presenter is our very own MC, Shamima Banu Mohammed Ansari. She's a third-year medical student who will be presenting her work on investigation of key factors influencing transition to learning in the clinical setting. Shamima?
Yeah, thanks, Priya. So I'm just going to share screen. Okay, so my name is Shamima. So my project was on the investigation of key factors influencing the transition to learning in the clinical setting. And I would like to thank my supervisors from my second year selective, Dr. Helen Ochsner and Dr. Alison Green, for their guidance in this project. So in the medical and health professional programs, the transition between the theoretical and the clinical phase of the program has often been very characterized as one of the most stressful periods. So stress, as we know of, can be both conducive as well as inhibitive to learning. It can be a very powerful motivator, but at the same time, it can become counterproductive if it's present in excessive levels. So there is very little empirical evidence out there as to what are the specific factors that are required for the students in order for them to reduce this stress during the transition from their preclinical to clinical years of their medical and health professional programs. So the aim of our project was to explore the key barriers as well as enabling factors to help reduce the stress for students during this transition from preclinical to clinical years of learning in their medical and health professional programs. So with our aim in mind, a scoping review was conducted to try and map the available evidence, as well as considering this potential for more information to be discovered, as well as the presence of the diversity in research methodologies that was available in this area. So the review was drawn on the guidelines by the JBI manual, as well as structured according to PRISMA checklist for scoping reviews. Our eligibility criteria for the literature was drawn up with respect to the population of medical and health sciences students. Our concept was on stress and anxiety in the context of preclinical to clinical transitions. So we had 3 databases for our literature search, PubMed, ERIC, and CINAHL, with the limits on years as well as language applied. So our literature search from the databases produced 733 articles, and following the screening and full text reading, we ended up with 46 articles to be included in the final synthesis of results. And the data was then extracted and tabulated, which included study demographics, design, the aim of the studies, as well as the participant details, any outcome measures, and as well as tabulating their results as well. So the review results was analyzed in 3 main areas. One was the barriers 2, the enabling factors, and 3, the coping strategies to reduce the transition stress. So in terms of barriers, the analysis revealed 4 main themes. And if you were to unpack these themes a little bit more, so first theme is a sense of inadequacy that is often felt by the students due to insufficient knowledge, skills, and experience. They also harbor this fear of making mistakes, which makes them more stressed. Secondly, there are certain features of the clinical environment, such as unfamiliarity and the ambiguous roles and responsibilities of the students in the wards, increase their confusion and stress. So furthermore, the different clinical tutors having different teaching styles also create difficulty for the students. And some students also report that witnessing pain and suffering of the patients to be a significant source of stress for them. Thirdly, would be the lack of support for the students in terms of poor relationship with their preceptors and the fear of just being a burden in the clinical team, which was noted to be causing stress and tension. And lastly was some practical issues and logistical issues such as location of the placement and associated costs of travel and accommodation that contributed to the student stress. And students also reported that placements that are of short duration didn't allow them enough time to adjust and perform, and thereby generating stress. So this brings us to the enabling factors to reducing stress during this transition. And 3 main themes were identified there. So firstly was finding a legitimate place within the clinical team that played a key role in lowering the stress in students. So this enabled them to feel welcomed and have a sense of belonging to the team. And in addition, students who used initiative and engaged in self-directed learning were more easily able to find their place in the team, which in turn helped them to reduce the stress. Secondly was preclinical patient encounters enhanced their familiarity to the clinical setting. So it helped to reduce the student confusion and stress as well. And when students had also continuity with their clinical teachers and administrators throughout their placement, much better rapport and relationships could be built. And lastly was support for the students in terms of orientation activities or provision of close supervision by preceptors help them to aid in establishing a student confidence, and also having a supportive relationship with the mentors as well as role models allow the students to communicate any concerns that they have and relieve their stress. So this brings us to the strategies that could be employed in try and reduce the student stress during this transitional period. So these strategies could be broadly divided into preclinical strategies and in situ clinical strategies. So preclinical strategies included simulation-based orientation as well as transition courses prior to starting the placement to teach students some pertinent skills that can help them teach the skills that are specific to the placement that they're going to start. And sharing of the clinical experiences by senior students was also another useful strategy that arose, as well as it was also suggested to divide the students into groups and teach them skills that are specific to the placement as well. And during the clinical placements, increased communication between the academic and the placement staff could also possibly reduce any confusion and increase clarity in terms of administrative matters. And also it was found that when students start placements with lower workloads and then gradually increase the intensity of the activities, then the transition was smoother then. Another strategy was also pairing the students up, especially during the initial days of the placement, as well as giving regular structured feedback to allow the students to navigate through their progress. So in conclusion, minimizing the student stress in the clinical environment is a very crucial step toward optimizing educational experiences, as well as safeguarding the students' mental health. And this will also help in reducing attrition rates of healthcare workers. So this has implications in creating a better, safer, and high quality healthcare system. Future research in this area is recommended to widen the scope of this review to try and identify any standardized measurement tools to measure stress, as well as addressing the preceptors' perceptions of student stresses within the clinical environment as well. Yeah, thank you. That's my end of the talk.
Thanks, Shamima. That was really great and really relevant. Our next speaker is Jenny Kuo, a fourth-year medical student who will be presenting her work on diagnostic accuracy of serum and urinary biomarkers to predict acute kidney injury in premature infants, a systematic review and meta-analysis. Jenny?
I'll just share my screen. Yeah, I think you guys can see that now. Okay, so I'm Jenny, and my project was serum and urinary biomarkers to predict acute kidney injury in premature infants, and this was a systematic review and meta-analysis of diagnostic accuracy. I did this project with Lisa Atkinson and Mark Chatfield, and supervisors Peter Trinker and Karen Moritz. So, acute kidney injury, or AKI, is the clinical syndrome characterized by the acute decrease in kidney function, which encompasses both injury, which is structural damage, and impairment, which is loss of function. So there are approximately 15 million babies born prematurely each year worldwide. Premature infants are at high risk of developing an acute kidney injury due to their immature and poorly functioning kidneys. The incidence has been estimated to be between 12.5 and 40%. So current AKI diagnostic criteria utilize serum creatinine and urine output changes. However, these are problematic as they have poor accuracy. Serum creatinine may lag up to 72 hours after the initial injury, and neonatal serum creatinine reflect maternal concentrations. Non-oliguric AKI is also common in infants, so biomarkers with better diagnostic accuracy are needed to identify these infants early. So this systematic review was completed by searching 5 databases: PubMed, Embase, CINAHL, Scopus, and the Cochrane Library from inception until October 2019, and an updated search was conducted in August 2020. So the search strategy used mesh and free text key terms that covered infant, pediatric, biomarkers, and AKI. All included studies had methodological quality and validity assessed using a modified standards for reporting diagnostic accuracy criteria. So here are the inclusion and exclusion criteria. The inclusion criteria was essentially premature infants who had a biomarker measured in urine, serum, blood, or plasma. Studies must have reported measures of diagnostic accuracy and have a clear definition of AKI. Only human studies and English publications were included. Exclusion criteria were having no reported diagnostic accuracy measures for any of the biomarkers, no development of AKI, and conference abstracts, PhD dissertations, review articles, and other editorials were excluded. So from the initial search strategy, 2,118 articles were identified. After studies were reviewed against the inclusion and exclusion criteria, 15 articles were included in the final systematic review. All studies were shown to be of good quality, and then a total of 6 studies were included in the meta-analysis, which I'll discuss later. So a total of 27 biomarkers were identified from the 15 studies that were included in the systematic review. 22 of these biomarkers were in the urine and 5 were serum biomarkers. So as you can see, urine NGAL was the most frequently investigated, with 8 studies investigating this. There were a couple of other biomarkers investigated by 2 or 3 studies, such as osteopontin or OPN and EGF. But the majority of these biomarkers have only been investigated in 1 study. So good diagnostic accuracy is defined by an area under the curve of greater than 0.7. So the urine biomarkers that are highlighted in bold were all shown to be of good diagnostic accuracy. However, as I mentioned before, a few of these have only been investigated in 1 study each, and these studies had small sample sizes. So of the serum biomarkers, cystatin C was the most frequently investigated, and unsurprisingly, it showed very good diagnostic accuracy with area under the curves between 0.88 and 0.97. But serum biomarkers are problematic in this population, as repeated blood samples would be needed to monitor renal function. And as you can imagine, in a premature infant in particular, this blood loss would be significant and may cause further complications. So urine biomarkers would be favorable in monitoring renal function in premature infants. Serum NGAL, PON1, TOS, and TAS also showed good diagnostic accuracy. However, these are only, this is only at very certain time points. So a meta-analysis could only be conducted on biomarkers investigated by 4 or more studies due to the constraints of the program that was used. So a meta-analysis could only be conducted on urinary NGAL. Although 8 studies looked at urinary NGAL, only 6 studies provided sufficient information.
So from those 6 studies, there was a total of 288 participants with 195 having no AKI and 93 having AKI. So this table here shows the studies that were included on the left-hand side. And then there are the sensitivities and specificities and the area under the curves here that were used to calculate the 2x2 contingency table, which is the last 4 columns, which shows the true positive, false negative, and true negative values. So that table, the last 4 columns there, that table was used to construct the HS-ROC curve, or the hierarchical summary receiver operator characteristic curve. So the gray circles represent each study and their different sizes to illustrate the sample size. And then the red square is the summary point, which showed urinary NGAL had a sensitivity of 77% and a specificity of 76%. The area under the curve was 0.83, which indicates that urinary NGAL has very good diagnostic for AKI in premature infants. So lastly, I constructed a Fagan's nomogram. This is a clinically useful tool. Pretest probability is the probability of AKI before a urinary NGAL test. This was set to be 25% to be conservative, as the incidence was estimated to be between 12 and 40%. So after a urinary NGAL test, positive post-test probability doubles to 52% and a negative post-test probability decreases to 9%. So in conclusion, several promising biomarkers have been identified. In particular, urinary NGAL and serum cystatin C have been shown to be of very good diagnostic accuracy for AKI in premature infants. If we can use biomarkers to diagnose AKI early in premature infants, this might lead to more appropriate clinical management of these infants with potential to prevent long-term consequences of AKI, especially progression to CKD. Thanks.
Thank you, Jenny. Our next speaker is Alice Zhang, a 4th-year medical student, who will be presenting her work on short and long-term outcomes of older surgical patients admitted to ICU after surgery.
Okay. Sorry, give me a sec. Okay. Are you able to see my screen there? Is that showing?
It's showing.
Okay, thank you. So, wait. Okay. Oh my goodness. Okay, that works. Sorry. Hi everyone, I'm Alice, and I am honored to be here to talk about my research project on the short and long-term outcomes of older surgical patients admitted to the ICU post-operatively. So I started working on this project because during my 3rd-year surgical rotation, I encountered a lot of patients who couldn't undergo their surgery for no other reason besides that there was no ICU bed available to them for post-op monitoring. I'm sure many of you have encountered a similar issue, or perhaps were even the bearer of bad news. And so I subsequently sought to research ICU resource allocation. And so when it comes to surgical patients, being older than 65 years old is an independent risk factor for complications. Older patients are more frail at baseline, they deteriorate faster in response to acute stress, and they're often admitted to ICUs post-op just in case. However, there isn't really any strong evidence to show that critical care admission improves patient outcomes, and ICU beds are limited. So Australia's fast-growing aging population is creating a critical care supply and demand mismatch. This means that we either need to build a lot more ICUs to accommodate our changing population, or we could rethink our use of critical care resources. So the objective of this project was to focus on the latter and identify the prognostic factors that can predict which patients will benefit from ICU admission. We wanted to determine, firstly, the mortality of older post-op ICU patients from admission and when they were in hospital until 1 year post-ICU discharge. And secondly, we wanted to assess the morbidity outcomes of these patients up to 1 year post-discharge as well, meaning their rates of admission to inpatient rehabilitation, their rates of palliative care referral, and their entry to an assisted care facility. In order to do this, we conducted a retrospective study at a metropolitan hospital, collected data via the ANZIX database, and did manual chart review. We included all post-op patients older than 65 years old and then who were subsequently admitted to the ICU over a 5-year period. And we didn't try to exclude anyone, but 12 patients did not have all the data we needed, so they were excluded. And of note, this center did not do any cardiothoracic surgeries. We collected a whole lot of variables, as you can see on the screen. And to note, we separated major and minor surgeries based on the extent of surgery invasiveness that other literature has used before. Our results, in total, we had 370 patients in the study, mean age 77.5 years old, mean Apache 3 score was 57, and that indicates that overall we had a pretty sick population. Of the surgeries that we flipped through, GI, ortho, and GUT surgeries predominated, as did major surgeries and as did emergency surgeries. The overall hospital mortality was 8%. Overall 1-year mortality was 18%. 71% of all patients were discharged to their own home, and 61% of survivors at 1 year managed to escape all the morbidity outcomes. So regarding mortality, let's have a closer look at the prognostic factors that we were investigating. Being older than 85 years old conferred a 4 times greater relative risk of dying in hospital and after 1 year compared to being 65 to 74 years old. And same goes for emergency procedures and for patients with an Apache 3 score of greater than 50. Regarding morbidity, you can see here that being older than 85, again, was the only factor that significantly increased patients' risk of morbidity outcomes across the board. So we're looking at ICU and hospital length of stay. Emergency surgery was the only factor that significantly increased ICU length of stay, while older age and higher Apache 3 score predicted a longer hospital length of stay. Okay, so let's combine these factors together. And let's say we have a patient who's aged greater than 85 years old, who's about to undergo major emergency surgery. And they ask you, doctor, what's my chance of surviving this? What is my chance of ending up in a nursing home? So we can show them this data. And in this highly vulnerable group, they have a 20% chance of dying in hospital. They have a 45% chance of dying within 1 year after ICU discharge. And on average, they will stay 25 days in the hospital. Of the patients who survive their hospital stay, 22% will end up in inpatient rehab, 16% will be referred to palliative care within the year, and 14% will enter an assisted care facility within the year as well. So those outcomes are not very good. The significance of the study is that it's the first Australian study to assess long-term outcomes of older post-operative ICU patients. And the results that we have are comparable to international studies as well. So given that we now know that patient outcomes can be pretty poor, we recommend revisiting the risk to benefit discussion regarding surgery and critical care admission, with the emphasis on preserving quality of life. According to the Australian Bureau of Statistics, 1 in 5 Australians older than 85 will rely on institutional care facilities. We know that Australians prefer to die at home, They don't want to die in a nursing home, and yet government data shows that paradoxically, only 14% of Australians die at home, 54% die in hospitals, and 32% die in residential care. And so the greatest obstacle to improving quality of death and quality of life is failure to discuss end-of-life options, and therefore failure to enact on personalized choices. So understandably, in an emergency situation, these discussions are hard to make. Therefore, we propose several strategies to improve the disparity. We should initiate end-of-life discussions before life-threatening events arise. We should normalize this type of discussion by increasing patient and physician awareness. We should encourage legislative or guideline changes to ensure wider implementation of advanced care planning. A couple of limitations of this study include that it was only a single center study with specific protocols, although results are kind of generalizable as compared to international studies. We had a moderate sample size that inhibited analysis of some groups. We didn't include the patients who were not immediately sent to the ICU, for example, those who were stepped up from the ward. And the nature of death of patients was not collected, which is kind of like a missed opportunity. I think there's further analysis to be made there. And finally, we didn't differentiate between planned and unplanned ICU admissions. So to conclude, older surgical patients admitted to ICUs after surgery are admitted liberally. However, ICU resources are limited and critical care may not be the best option for everyone. Age over 85 strongly predicts short and long-term mortality, as well as poorer long-term morbidity. And an Apache 3 score of over 50 in emergency surgery will strongly predict mortality for patients, but not necessarily morbidity. Okay, that's all for me. Thank you.
Thank you, Alice. That was a great presentation. Our last student speaker for today is Zorana Linton, a second-year medical student who will be presenting on the structure-function paradox of callosal absence. Long-range axonal plasticity may not be necessary for the recovery of functional outcome.
Thank you. Hi, I'm Zorana, and I'll be presenting just a sliver of my PhD project. So I just wanted to draw attention to this image, which shows a Probst bundle, and I'll be elaborating on that in a minute. So I'm studying brain plasticity, which enables our brains to adapt and learn. And we have known for decades that children have a greater capacity for plasticity than adults. The overarching question that I'm trying to answer is which mechanisms of plasticity allow children to recover functionally when compared with adults. And this is a clinically significant question as it can help us identify modes of plasticity that can be enhanced in adult brains to preserve function after brain injury. So the corpus callosum is an excellent structure to study this question. It is the largest fiber bundle in the brain, and it connects the right and left hemispheres to enable interhemispheric communication. And this is crucial for higher cognitive functions. So the significant function of the corpus callosum is highlighted in callosotomy outcomes. Callosotomy is a procedure that is reserved for palliative epilepsy management, and it involves surgically dividing the corpus callosum fibers. When this procedure is done in adults, there's usually a resulting chronic disconnection syndrome, and that's characterized by impaired bilateral communication. So a particularly severe example to demonstrate this is alien hand syndrome, where one hand performs tasks without conscious control, and that makes tasks requiring cooperation of both hands, like buttoning a shirt, extremely frustrating. There's no chronic disconnection syndrome when this procedure is done in children. So here we're already starting to see that callosal structure function paradox. A different condition where this structure is affected is agenesis of the corpus callosum, or ACC, where the corpus callosum is congenitally absent, as you can observe missing callosal fibers. Additionally, these brains have aberrant bundles. They're shown here in green, and they run longitudinally in the anterior posterior axis, and they're called Probst bundles. People with ACC do not experience a disconnection syndrome, and there's some evidence that Probst bundles may be functional and aid in callosal compensation. So to summarize, we see a structure function paradox where early callosal loss, like in agenesis or pediatric callosotomy, results in no disconnection syndrome. And late callosal loss, like in adult callosotomy, there can be major neuropsychological consequences. I'll be using a yellow background to indicate the human conditions throughout the rest of this talk. So one of the most popular mechanisms to explain plasticity in callosal absence is long-range axonal plasticity. So as the brain is developing and axons are finding their targets, they reroute through alternative pathways when they encounter a barrier, so like this cone. And this can create novel aberrant routes to connect brain structures and may underlie preservation of interhemispheric connectivity. I use two different techniques to examine axonal pathways. So the first is diffusion MRI and tractography, where the diffusion of water molecules is used to reconstruct probabilistic fiber bundles in the brain. So there are these colorful bundles here. And secondly, I use in utero electroporation. This is a precise method of labeling axonal tracts. So briefly, I conduct laparotomies on pregnant mice and I expose the uterine sacs. I inject negatively charged DNA into the ventricles and they encode for a fluorescent marker. I use a positive electrical pulse to direct the DNA into the somatosensory cortex, that's S1, S2, and this ends up labeling neurons that project their axons through the corpus callosum as the brain continues to develop in utero and after birth. The brains are then collected and sectioned coronally as depicted here for analysis. We developed several different mouse models. So I use a callosotomy mouse model to cut the corpus callosum at either juvenile or adult mouse stages for childhood and adult callosotomy respectively. For our ACC model, we use an inbred mouse strain where half the litter is missing a corpus callosum and the other half serves as a control. To control for the genetic factors in surgical procedures, we do a very early callosotomy procedure that disrupts the midline before those labeled axons cross. So we avoid cutting the labeled axons to additionally model ACC. And of course, we do sham surgical procedures to control for all the surgeries. We allow for 15 days for plasticity following the procedure or birth of the mouse before analysis. I looked at multiple areas throughout the brain, but for the purpose of time, I'll just present the aberrant bundles that we identified. So first are the PROPS bundles. And we already know that these are found specifically in humans with agenesis of the corpus callosum. And indeed, our inbred mouse model of ACC had PROPS bundles as well. Interestingly, our early callosotomy mouse model of ACC also had PROPS bundles. So this is showing that we can surgically induce similar patterns of plasticity. We did not see PROPS bundles in either childhood callosotomy or adult callosotomy, which is consistent with what is being reported in humans. We also identified a novel aberrant elaboration of axons in the anterior septum that has never before been described. So that's this red bundle here. This was only observed in our ACC models and not in the juvenile or adult callosotomy. And it is unknown if this also exists in human brains. I further quantified the elaborated axons and found that they are significantly increased in our ACC mouse models, but not in the juvenile or adult callosotomy. And if we look at a close-up of the midline, we found that some of these aberrant axons actually cross and pose a physical connection between the right and the left hemispheres of the brain. So I'm further following this up on the functional targets of these axons to determine whether or not they're preserving interhemispheric communication. To summarize, there's no clear pattern of long-range axonal plasticity in mice and extrapolated behavioral outcomes from humans, but we need to further conduct behavioral tests on mice to confirm this relationship. We additionally uncovered a novel aberrant axon bundle that enables axons to physically cross the midline, and this research prompts a deeper investigation of other plasticity substrates that may explain the structure-function paradox in acallosal brains. I just wanted to acknowledge the Richards Lab and our funding sources, and thank you for listening.
Thank you so much, Serena. That was really interesting. We'll now be taking any questions from these presentations as well as a few from the previous set if we have time. So we have a couple from Chloe from the previous set of presentations. How stable is the microbiome over time and age?
Sure. So there are big shifts in the microbiome with age, and that's particularly during development, and that tends to correspond with dietary changes. So when kids go from breastfeeding and then wean and then build towards a more diverse diet, the microbiome does change a lot. Overall, though, I think the causality is really hard to disentangle. So like how much of this is intrinsic? Is it dietary? Is it immune development? Is it gastrointestinal issues? Because some kids just get constipated and no one really knows why. And there's a lot of kids who also take antibiotics for various reasons when they get sick. And so, I mean, I think in the context of our study, I think one reason why we had such big variance estimates for age is because we looked at this pediatric sample, and that's when all this change occurs. And so then you might be better able to predict or delineate how old a kid is based on their microbiome profile relative to the others, because just based on age, they'd be quite different. But I guess past the pediatric sort of window, and then we get into adulthood, I think the microbiome, from what I've read, does become more stable. But again, that's subject to dietary habits and I guess associated behavioral changes and medication use. So for example, when people get elderly and they go into a tea and toast diet, I think that could also reflect some pretty big changes as well.
Chloe, we have another question for you. Some pediatric neurologists believe autism begins in utero with soft signs evident even at birth. Date of diagnosis may relate to the time of referral to a specialist. If this is the case, how would diet or microbiome possibly impact the postnatal development of autism?
Sure. So I guess, yeah, again, this could be related to that kind of confounding issue. But perhaps some other things to also consider on top of that is, firstly, if a kid's diet is so restricted that they become malnourished, and there are definitely a lot of case reports, and there are many instances in which kids had to be hospitalized and have enteral feeding because they have such severe food selectivity, then I think that could affect neurodevelopment if you're not getting essential amino acids, vitamins, and minerals. And another thing that could contribute to a more challenging behavioral profile perhaps is if you have food intolerances and allergies and you have stomach pain and you just feel really unwell, then it's kind of not really a surprise that behaviors would be more challenging, and that could lead to this, correlation with quote unquote severity, and I use that word with a bit of reluctance, but I think that this picture could also all contribute as well.
Thanks, Chloe. Shamima, we have a question for you. Great review of the literature. Were there scientific comparisons in some of these studies that would allow meta-analysis of the data?
Yeah, so I think one of the limitations of our review was that there was a lot of heterogeneity in the sample characteristics and the tools that we used to measure the stress and anxiety as well. But that being said, there were a lot of comparisons and there were multiple sets of themes that arose which were similar across the papers. So yeah, I would definitely think meta-analysis would be a good future direction for this project.
Thank you. Does anyone else have any more questions? Oh, we do. We have a question for Zorana. What age mice did you use for your adult population? And would you anticipate different effects in different adult age groups, like middle age versus senescent?
So for our adult population, we used P30 mice, so that's 30 days old, and that's considered a very early adult stage. Whether I would anticipate different effects in adult age groups, we know from what we can extrapolate from human behaviors is as you, after you reach adulthood and that critical window is closed, you don't really see any very large changes, but it does take longer if any changes do occur. So if we do notice anything in adults, likely in our P30 early adults, it'll happen much quicker than if in a senescent adult where it may take much longer. Good question, thank you.
Thank you. We also have a question for Alice. How much of the age effect chronological is actually frailty, physiological age, and reserve loss?
Okay, so thank you for the question. I guess the best estimate that I can give on whether or not people who are older are actually more frail and have decreased reserve is by looking at the Apache 3 score, which, if you're not entirely sure, it involves a whole range of physiological markers and incorporates cardiac, renal, and all these other comorbidities to generate a score. And that could be a pretty good indicator of frailty and of reserve. And so for all of our patients over the age of 85, overall they had the highest Apache 3 score of 69.5. And that's compared to patients who are younger and 65 to 74 years old. Their Apache score was about 50.
Thank you. Oh, go ahead. Okay. I'd like to thank all of our speakers for their hard work and all the participants and judges for your wonderful questions. I would like to now introduce our keynote speaker, Professor Ruth Hubbard. Ruth is the Masonic Chair of Geriatric Medicine at UQ and a consultant geriatrician at the PA Hospital. Her main research interest is in frailty in older people, and she is ranked number 3 in a list of frailty experts worldwide. She is currently supervising 4 PhDs and 2 MPhil projects and has generated more than $9.3 million in grant income in the last 5 years. Professor Ruth Hubbard.
Thank you so much. Yes, I'm online. I can't share my screen until you've stopped sharing, I think.
Yes.
Thank you so much.
Okay.
Sorry, I'm just trying to get this up. Are you able to see that?
Yes, we are.
Excellent. Right, thank you so much for the opportunity to speak today. My research is slightly different from some of the presentations we've been hearing about because I'm a clinician, and I'll just tell you a little bit about the work that I'm doing. I have a couple of objectives today. I'm going to be providing a brief overview about the research that I'm doing and discuss my own path, my career path, and then review some of the pros and cons of research and hopefully generate some questions and interest in that. So the underlying reason for me to undertake my research is that chronological age is not an accurate marker of somebody's health status. So this is encapsulated by comparing the Queen, who is 94 years old and still able to ride a horse, with some of these residents of an aged care facility who are in their early 70s. And the concept of frailty, as Alice has just been fielding questions about, has enabled us to understand some of these differences in health status. So frailty has been defined as a state of increased vulnerability to stressors, and a frail individual has reduced physiological reserve and a reduced ability to compensate for homeostasis. So I'm a geriatrician, as you said in my introduction. I work in the PA hospital and I look after patients on the rehabilitation ward there. And this is a figure that I draw often for families and patients themselves in order for them to understand their trajectories after being in hospital with an acute problem. So you or I are represented by the green line along the top here. So we have very high levels of functional independence. And if we have an insult like a cough or a viral infection, we feel unwell for a couple of days and lie on the sofa watching Netflix, and then we just bounce back to what we were like before. Whereas a frailer older person will have the same insult but deteriorate very significantly in their functional status, and they take a longer time to recover, and they often don't quite cross that threshold back to independence. So frailty is very important because it can guide appropriate management strategies and is a better predictor of adverse outcomes than chronological age. But the challenge is that everybody is measuring frailty in different ways. So there are 48 different measurement tools described in the acute care setting alone, and every discipline, so the nephrologists have their one frailty measure, and the liver specialists have another, and the surgeons are developing their own one. So that reduces the generalizability of findings, and is sort of putting barriers up between specialists being able to communicate with each other about patients' risk status. But the frailty index is considered the gold standard measure. So this is a way to quantify frailty in a really granular way. The methodology is that you count deficits across lots of different domains. So you need to have some measures of functional status plus comorbidities. And this is the problem with the Apache score that I was going to point out to Alice, that it doesn't have much about function. So it wouldn't give you a true measure of somebody's frailty status, because somebody's ability to manage their personal and instrumental ADLs are really important when it comes to assessment of frailty. And also include comorbidities, measures of cognition and the sensorium. And you need to have about 30 or 40 deficits to derive a frailty index. And then if you have 10 deficits out of the 40 counted, your frailty index score would be 0.25. And there's precedent in the UK for deriving a frailty index on everybody. So there, when people go along to their GP, if they're over the age of 75, because the GP will ask them about their function and their cognition and their vision and hearing and their comorbidities, they can automatically generate a frailty index for that population. But it's never been integrated into the acute care setting anywhere in the world. And this drew me to this not very scientifically robust diagram of our current knowledge in healthcare, which just indicates that we know an awful lot about interventions that can be done to people and pharmacotherapy, and we've got lots of technology that we understand, but we know a lot less about the health status, how to quantify the health status of the individual at whom that's aimed. And as previous speakers have said, we know even less about what patients want from their healthcare episode. So this is just illustrating some work that Professor Midwinter and I will be pursuing over the next few years, which encapsulates how if we could get patients coming into the acute care sector to have a frailty index, we would then be able to try and individualize their management across different disciplines, and we could start to understand what causes aging by undertaking some deep phenotyping of patients, which we could relate their sort of hormonal changes or cellular changes or biomechanical changes to their frailty index score rather than just their chronological age. We would need to partner with the mathematics, and then we could think about how to mitigate the effects of frailty. So one model that we're going to be investigating in the next year or so is organ transplantation as a model of reversible frailty. So this poor chap is waiting to have a liver transplant, and he has a high frailty index score. So he's got lots of deficits at the moment in terms of his ability to mobilize and his cognition is a bit clouded and his gait pattern will be impaired. But then when he has the liver transplant, he's transformed and he's got a very low frailty index. So it would just be fascinating to undertake some deep phenotyping of this chap and see what happens after his intervention, and then to compare that to older people who have a high frailty index score to see what changes are precipitated by chronological age as opposed to acute disease, because we can compare frail older people to fitter older people in relation to their deep phenotyping. So that's a little whiz through my research, which I wanted to include just because I love it so much. But you're probably more interested in my career path and how I've come to be in a position to do clinical practice and research. And it's been not exactly straightforward. So this is a diagram illustrating what I've done over the last 20 years. And I would encourage you to ask the seniors that you're working with, so whether they're scientists or clinicians, to tell you how they have got to where they've got to, because we've all got different journeys. And I think it would be a nice little project for a student actually to just interview 10, because I wonder if the women have very different trajectories to the men. But this is what I have done personally. All right. So I went straight to medical school after school and graduated as a doctor just over 20 years ago. And for the first 6 years, I just focused on clinical practice. So I got through all my exams, trained to be a general physician and geriatrician. And then I stopped doing anything at all. And that's because I had a baby. That was my first non-research output. So all these periods of not doing anything are like baby, baby, baby. So it is possible to have like reasonably prolonged periods out of the clinical and research environment. So then after my baby, my first baby, I went back into clinical practice, but also did a master's in medical education, because I thought, well, I want to do something a little bit more than just clinical practice, which is what I'd been doing that whole time before. So I did a part-time degree in medical education. I quite enjoyed that, and then completely dropped it for a little while. And then I did my research higher degree in frailty, surprise. So that took up a couple of years. And I did that at the same time as clinical training. And then stopped doing anything and became a consultant in 2005. So that was associated with some leadership, because you do have clinical leadership as a consultant. And then I enjoyed my research so much doing my research higher degree that I went to Canada for 2 years and just did research. So there I was a postdoctoral fellow. And I think if you are thinking of a career in research long term, it's really important to have some time overseas working in the best research group you can find. So I went to Canada and worked in Nova Scotia with Ken Rockwood, who's the best frailty expert in the world, and just absolutely loved that. So all this time I'd been trying to juggle different things, and it was just so nice for me to have some time out of clinical practice to focus on research. And then I went back to Wales. So I had 2 years in Canada and went back to Wales and did a job which was a bit of a lecturing job. So I was reinvigorating my medical education expertise there, but it was mainly clinical. So having not done clinical for a couple of years, I wanted to do the busiest clinical job I could do. So I was working in a very deprived area in Newport in South Wales as a general physician consultant. Then had another baby, and then was looking for academic opportunities, and there was nothing around in Wales. So I came to Australia thinking, well, I'll stay here for a year or so, and here I am still, because I just love living here. But I started to do, so I came here because I had the opportunity to do a job that was half clinical and half research. And so enjoyed that for a while. And then an opportunity came up to head up the clinical unit and to work with the medical students, to work with you guys for a while. And so I played my medical education card again and said, oh, look, I've done this degree in medical education. You know, I could do this job. And so I've been head of the clinical unit for 4 or 5 years. And the head of the clinical unit job isn't just about medical education. It's also about leadership. So my sort of green line has gone up and up and up. And over the last few years, I've got quite a lot more confidence about leading a big team. But now I've stopped being the head of the clinical unit, and I've got a job as the doing a bit more research. So this is the way my career is heading, that I want to focus now for the next few years on research and try and get some of those ideas off the ground that I was talking to you about. So yeah, I'm not expecting you to memorize all of that, just for you to see that there are periods where because you can't do everything all the time. So it's quite nice to be able to have different strands to your career that you can concentrate on more for some periods and let other things go. So the pros and cons of research, this is my last but one slide, and you can see from this robust investigation into the pros and cons of research that there are more pros than cons. So the pros are that it just adds this whole new dimension to your clinical work. So it's interesting, it's diverse, it's relevant. And in something like geriatric medicine, we've got such a need to understand what we do and to improve the care of older people. And as a clinician, you would be able to apply some of your research findings to make care better for patients. The opportunity to travel and meet people makes me sound like a Miss World contestant, but it is, research does open up all sorts of opportunities to interact with groups of people that you wouldn't as a clinician. But there are cons that need to be acknowledged. So it takes a lot of time. It's just a different clock in research compared to clinical practice. If you like immediate rewards, you should head straight for the emergency department, where you'll be juggling patients and sorting them out immediately. But research it takes a lot more time to set up than that, as I'm sure many of you have appreciated already. It's not financially attractive. So Queensland Health consultants get paid a lot more than anybody involved in research here. And it does involve lots of juggling. And in research, you never really finish. You never really feel you've achieved everything. So you'll be working towards a grant or on a paper, and then as soon as that's done, the next one emerges. So if you don't like to be under pressure, then research may not be the career for you. But I'd be interested in your own perspectives of how you have managed to incorporate research into your MD programs, because you guys are all so way ahead of me, because I didn't even touch research until about 10 years after graduating. So the last thing I wanted to say is that there's a long road ahead of you as a clinician, and you'll have periods where you doubt yourselves and you doubt what you're doing, but you just need to keep your heads held high and have courage and deal with the uncertainty, because it's all worth it in the end. It's a really rich and rewarding career that lies ahead of you. There will be moments in the shadows as well as moments in the bright sunshine, but I wish you all the very best. Thank you.
Thank you so much, Professor Hubbard. That was really inspirational for us, female future physicians and researchers especially. I'll just ask, there are a few questions in the chat for you. Or if you have any questions for anyone. Okay. So our first question is, thank you for your presentation, Professor Hubbard. A slightly tangential question based on frailty and aging research. I have heard about some proprietary tests which claim to calculate a biological age for patients based on a blood test combining a variety of biomarkers. Is this something that has any real clinical relevance at the moment?
So not yet, but it has potential, and I think that there's a lot of interest in biological age and whether frailty can be used to quantify that. I think the frailty literature has moved slightly away from those ideas towards stratifying risk within people of the same age. So people aged over 85 are going to be more at risk because you would have accumulated some deficits by then, but the frailty index will enable you to stratify risks independent of chronological age. So that's the way we're trying to conceptualize frailty at the moment. But there are going to be biomarkers, and it's going more likely to be a suite of biomarkers than like a single agent, because frailty isn't going to have a linear deterministic pathophysiological pathway. It's going to be complex. But this is why I'm so excited about my program of research now moving forward, having done this job for nearly 2 weeks, that I think that there is so much that we need to understand about aging and pathophysiology of frailty. But getting a standardized frailty measure would provide such a platform for that to happen. So yeah, it's very exciting.
Thank you. The next question is, in your career path graph, did some years add to over 100% FTE? How did that work?
That's Chloe being a scientist. Yes, some of those ended up more than 100%. So I think that the leadership, I wasn't particularly counting some of the time as being, oh, now I'm leading, because it doesn't really work like that. It's just something that is incorporated into your working role. So I just wanted to show how that had sort of started when I became a consultant and was starting to increase. Yeah, but I don't work 40 hours a week. I was asked at the interview for this chair, did I think I was a role model? And I said, well, I'm not sure. Maybe I am to some people, but to others, I would be an example of what they don't want to do in medicine, because I'm just completely authentic about the fact that, yeah, it's hard sometimes. And sometimes you have to lean in, and you'll get home from work and have a few hours with your children, and then you've got to open your laptop. You've got to put in the extra hours. And if you don't want that as a career, and if you don't want those moving goalposts, then, as I say, you can do a 9-to-5 job, because a clinical academic is not that. But then, then I get to pick my children up from school some days. You get the flexibility to offset some of those extra hours, and so I feel very blessed about my my ability to do that. And as I say, I've had like at least 6 months off with each of my children and been able to come back into the workplace, and I don't regret any of that. There was no pressure on me to go back early, and so that was a very positive thing. Yes, Chloe, it does add up to more than 100%. And sometimes that's hard, but it gets easier to manage also as you get a bit older, because when you're younger, you want to say yes to everything, and every invitation is seen as a great opportunity that might be the real pivoting thing for your career. So you try and do everything, but as you get a bit older, you think, nah, I can say no to that, but I didn't say no to this. So here I am talking about research. Oh, here's another question.
Yes. Oh, go ahead.
No, go ahead. I'm sorry, I won't take over. You
the next question is, I know there's been talk of designing and streamlining system to help early career clinician scientists. Do you have any information about that? And more generally, do you have any advice for researchers navigating the transition from working on supervisors' projects to developing their own?
Yes, so I think that a clinical academic track will be coming in Australia in the next couple of years. I'm not sure if it will be done in a timely way for you guys, but in the UK now, and it wasn't there when I was there, but there is this clinical academic track that protects some time for research, which is a real luxury. But on the other hand, there is no harm in having a few years in your career where you just focus on gaining those clinical skills, because you don't want to be the professor who comes onto the wards and all the nurses dread your ward rounds because you're so crap. So you want to have that really robust expertise in your discipline. And also, if you're trying to recruit your colleagues to studies, they're not going to want to help you if you're not a good worker, if you don't prioritize the patients. So that's another reason for me showing my career pathway, because there were periods where I had to drop things completely for years at a time, and then you just but that's why you've got the rolling hills at the end, because it's such a long, you've got a long time ahead of you. So there's no harm at all in letting things go for a while. Cody, that's a hugely rambling answer to your question. So I'm hoping there will be a clinical science track. I have no insights into when that's coming. Researchers navigating the transition, yeah, to independence. Just keep your heads down, keep working, and you know, suddenly you'll realize that instead of having 5 papers on your CV, you've got 25. And instead of helping other people write their grants, you're getting ideas for your own. So there's no magic dust for that. It'll just happen with your experience and with your confidence in your discipline. Thanks, Cody.
I just had a question. It's not in the chat, but I'll just ask you. When did you become interested in geriatrics specifically, or have you always been?
Yeah, so when I was a medical student, I used to bore my family to tears, because after every rotation, I would go home saying, oh, you know, I want to do obstetrics, you know, I even like flirted with surgery, but that was literally for 36 hours. That was because I thought, I'm a woman, wouldn't this be cool? But then I actually went into theatre and realized pretty quickly that wasn't my deal, because to do surgery, you have to just love operating. You have to love being in theatre. But so then I realized quite soon during my, you know, clinical years as a medical student, that I just thought old people were getting a raw deal in hospital. I thought they were generally getting a raw deal. And my consultants who I looked up to, you know, would say things like, oh yeah, you know, she's pretty good for 85. And I would think, what does that mean? You know, is that some sort of moral judgment about her character? Or, you know, even very sophisticated experts were talking about old people in seemingly meaningless ways in terms of grading their health status. So I became really interested in that quite early. And then, you know, I was quite good at medical school. I was good at exams, and people would say to me, oh, Ruth, you know, you could do cardiology. And I was like, well, no, I don't want to really. So I just wanted to advocate for this patient group who I felt were very disadvantaged. So yeah, forge your own path. And I wear it with pride being a geriatrician. I'm introduced to people at conferences and they say, oh, what should we call you? As if we don't want to call you a geriatrician. I'm like, no, I'm a geriatrician. It's like, I'm proud of it. So I acknowledge it's a low prestige specialty, but there's so much that we need to learn about, which is great if you're doing research in it. So find your tribe, find your specialists based on people you want to have dinner with. That's my top tip. Okay, you know, if you're doing the ward rounds and you're thinking you get on with those people, they're thinking in a similar way to you, then that could be a little indicator of the way to go.
That's awesome. Thank you so much, Professor Hubbard. I don't think we have any more questions. So I'd like to now introduce Professor Paul Kolditz, head of the School of Clinical Medicine, to announce the e-poster and oral presentation prize winners and to give the closing remarks.
Thanks very much, Priya, for that introduction. And I think we've really had a very nice exposition in Ruth's talk about a journey. You know, so often we're impatient to get to a goal. The goal's the next exam. The goal is getting that research out of the way. But look, it's a long path and there are many turns and there are many uncertainties. And of course, having arrived at being at the cutting edge, having just done the research project that you've done, we do find that having arrived there, you can't stay there. You were at the cutting edge, but by virtue of your contribution, the cutting edge has changed. So you need to change and adapt and generate the next piece of evidence. Now, all of that might sound pretty remote from someone old talking to people who are young and enthusiastic. But when I do some of my other roles, so I've just marked, for instance, the early career again. physicians, I've marked those who've applied for research funds available within the College of Physicians. So these are people who've been through the next phase, they've finished training in a specialty, they've got a PhD almost by definition at that stage to be back in the competition for, I've got a research question, I want to make a contribution. Now, what's the inevitable feature on their CV? These are brilliant people. I include people who've had ducks of high school, dean's commendations, and eye-watering GPAs. But of course, that's the tip of the iceberg. Not everyone's in that group. But the one thing that is common is this buy-in, enthusiasm to contribute, and it is a journey. You must start somewhere. In your commitment to spend some of your time not only doing the objective of getting to the end of the MD, but also thinking, when I go on a tutorial, I'm hearing this is standard practice. Well, is it really good enough? You know, I find myself asking medical students, well, you've just listened with your stethoscope. Is there a better way to do things? And of course there is. We shouldn't be relying on an analog transduction between a chest wall and your ears. We've got electronics, we've got artificial intelligence, that there are better ways to do things. And whilst our particular contribution as MDs in this process is around generating the clinical evidence, the best practice in the clinical environment, there are many others that we've got to bring along on this path. There are scientists, there are engineers, there are IT specialists that we can bring to the problems that confront our patients. So I wanted to remind people about the journey, and what we've seen today is an incredible celebration of diversity, diversity of topics, diversity of methods, diversity of broad categorizations of where you've made your engagement and contribution, and on that path towards providing better care for patients and for populations, of course, as well. So one thing that has been uniform, I think, has been the excellent standard of the presentations. Very commendable and very impressive. So I can see you're all getting impatient and you want to actually get to the goal of today's session, and that is to announce the winners. So I'll go through them, and of course, in terms of the presentations, of the posters, then they've been in various categories. Can I just check that that people are hearing me clearly? Yeah. Good. There's nodding going on there. Thanks. Because I only have one image on my screen here. So you'll recall that there are a number of posters in categories across clinical research, health services research, mental health and wellbeing, reviews, biomedical science, and case reports and protocols. Of course, there were not equal numbers in those. And so as I read through the winners in those categories, there will be more than one winner in some categories relative to others, which is relative to the proportion of contributions. And I'd like to thank and remind everyone and thank those involved, organised through by Professor Di Ely from the clinical research community to actually score and rank these winners. So the winners in the clinical research category Norden-Flaten on the title of hip fracture outcomes. Aidan Howard, the prevalence of non-respiratory sleep disorders. Fraser Labron, vertebral body wedging. Timothy Liu, defining patterns of inflammatory marker expression. Xinyi Lao, an analysis of clinical outcomes. Moving to the health services research category. Vikas Bansal, the ICD-10-AM codes for cirrhosis. Donald Chang, the impact of a novel multidisciplinary primary care approach. Tonchinyok Intrapasert, effects of prolonged masking and isolated protocols. Mental health and wellbeing category. We're down to 2 here because of the smaller number of entrants. Hannah Margolis and Samantha Jacko, that's one presentation, the positive and negative affect schedule. And Shamima Banu and Mohammed Ansari, the effectiveness of different methods of debriefing. Reviews, so there are 2 in that category. Jonathan Hill, a systematic review of contemporary methods, and Mary Cassis, incidental findings in the emergency department. Biomedical science category, we're down to 1 in this category. Burhan Khan, increased cutaneous bacterial load. And case reports and protocols, 1 in this category. Ibarami, Siddhis Kandaraja, Cri-du-Chat syndrome. So look, congratulations to all of you in across all of the kind of presenters and participants. Standards high. Those, after crunching the numbers, are the winners in the ePoster prize. Now, the other group is for the oral presentations. So this has been going on in real time over the last few hours, and we do have the final group, the final winners. So, and there are 4, and I'll name them in alphabetical order. Valina Charvaro, successful correction of sagittal imbalance. Cody Freer, for his presentation, cost effectiveness of negative pressure wound therapy. Zarana Linton, the structure function paradox of callosal absence. And Chloe Yap, restricted diet drives autism gut microbiota. So we have those 4 winners. I think congratulations again, very high standard. I know it's tough coming down to numbers, but having survived the MD program, you're pretty used to the rules, and they are the rules that you'll encounter out there as you hopefully continue to contribute to the cutting edge of medical practice, that endeavour of research and your continuous learning in the research space. And congratulations to all of you, and congratulations also to the various medical societies, OME in particular, for organising things. It's been a great morning, and certainly aligns with the commitment of the faculty and the MD program to really provide and encourage opportunity for student engagement, and for our clinical teachers to be involved in supervision. A great celebration of diversity and excellence. Congratulations, everyone. I think I closed the meeting on that note, but just back to you, Priya.
Thank you so much, Professor Kolditz. And thank you to everyone for attending, and congratulations to all the winners.